Hello, everyone. My name is Dr. Carl V. Hill, and I am so excited to be here today for the Duke Community Caregiver event. Today, I will be talking about the pursuit of health equity in Alzheimer's and dementia care from the perspective of the Alzheimer's Association. So really excited about today's discussion. So just to give you a bit of a sense of what we'll be covering today, I'd like to first level set on some important aspects of Alzheimer's and other dementia. And then second, talk a bit about Alzheimer's diversity and disparities, which is really important. Third, pivot around to some opportunities for enhanced inclusion and representation. And then finally, end our time with a discussion about a pursuit of health equity, right? So if we can focus on those four broad areas, I think our discussion will be quite stimulating. So about the Alzheimer's Association, our work is about community and science, really exciting opportunities that we have with the association with over 70 chapters located in various cities around the country. We have a real chance to engage communities and provide important information. If you see that symbol there, I'm sure you've seen it many places. On the right, that's a Florence flask that represents science and how that translates into protecting people's health and protecting public health, right? And so the association is a global organization. We fund research all around the world, and we're really focused in on advancing care and support and stimulating research that can lead us to advancements and treatment and care. So the Alzheimer's Association is leading the way in that regard. Also level setting here, just wanted to make sure that we're clear on terms. Dementia is a syndrome, right? It's a collection of symptoms related to cognitive or behavioral or psychological decline, right? And so Alzheimer's is the most common causes about 80% of dementia. But there are other types of dementia. There are Lewy body dementia, frontotemporal dementia. For today's discussion, I'd like for us to put a pin in vascular dementia, right? Vascular dementia is caused by blood that flows to the brain and that doesn't provide the brain with proper nutrients and oxygen that it needs to function properly. And it leads to the plaques and tangles that characterize Alzheimer's and dementia, right? So let's put a pin in vascular dementia. I want you to keep that top of mind as we continue our discussion here today. Also important, level setting here, are findings from the Alzheimer's Association Facts and Figures report that came out a few months ago. And so there are currently more than 6 million Americans aged 65 years and older living with Alzheimer's. That number is expected to more than double by 2050. COVID, we're all pivoting and persevering through the pandemic, right? So COVID is hitting people with Alzheimer's hard, with 42,000 more deaths in 2020 than expected. That's a 16% increase. And we'll talk a little bit about how that might be related to vascular dementia as we continue the discussion. And then finally, disease-related costs continue to rise. So in 2021, costs related to dementia are up $50 billion from 2020. So however you look at this, from an incidence perspective, prevalence perspective, health economics perspective, Alzheimer's and dementia is a public health priority which demands a very robust response. And the Alzheimer's Association is leading the way in that. One way that we help in this response is through our advocacy work, right? And so here you see the levels of federal funding for Alzheimer's research at the NIH, the National Institutes of Health, and that has gone up to $3.1 billion, up from $355 million in 2011, right? And so amazing work by our advocates around the country that are making it be known the importance of Alzheimer's research. And so this increase in resources does a couple of things. First, it allows early career investigators to receive training in Alzheimer's research. Really important. Those young junior Ph.D.s who just finished graduate school, they get a chance to receive a grant from NIH to kickstart their careers and hopefully dedicate all of their investigations to Alzheimer's research. And then there are the senior investigators who've done great work, received a lot of funding from NIH. They get an opportunity because of the enhanced resources to come over to this research area and help us understand the amyloid in the brain or some of the factors that are related to risk for various populations. So these resources are critical, and the association has helped to increase these at the federal level, really important. What these resources do and what the NIH does, and this is really important as we continue this discussion, is create Alzheimer's disease research centers, right? And so these centers are typically placed at colleges and universities around the country. And they house investigators who conduct research, and they think about some of the geographical factors, the cultural factors in the specific location, and how that might influence risk for various populations. So with the increased amount in resources, there are more grants, and there are centers all around the country that are doing this very important work, really important. Now, also, if you've been following the news, we're still level setting here. I'm sure you've heard about aducanumab, which is going by the name ADUHELM now, and the company Biogen created this treatment. It's an infusion, and it treats one of the hallmarks of Alzheimer's disease, amyloid, right? So it's an antibody that reduces amyloid in the brain. A lot of controversy here about its efficacy because of one of the trials was halted. But we at the Alzheimer's Association, we are excited about the first treatment that has been approved by FDA to not only treat the symptoms. Treating symptoms is really important for caregivers. And certainly caregivers are doing heroic work in this area. So we're not looking to undermine that. But this is the first treatment to ever influence the underlying cause of the disease, right? So slowing down the continuum of mild cognitive impairment to Alzheimer's. Really, really important. So we'll look for more treatments along this pathway, but it's really excited that ADUHELM is available. We certainly advocate for every and anyone to have equitable access to ADUHELM so that they can afford it and make good use of it. So kudos to Biogen, and we look forward to more study of ADUHELM and many more treatments in the pipeline that can help with the underlying causes of Alzheimer's. Really, really important. Now, I spoke of the continuum of cognitive impairment, and what ADUHELM would do is slow this continuum, giving families more time, giving people more time with their loved ones, caregivers more time. And as these treatments get better and better, they may even halt this continuum of cognitive impairment. So here you see that mild cognitive impairment is a known risk factor for dementia. What is mild cognitive impairment? That's impairment in 2 or more daily functions, things that you would do normally with ease, finding your car keys or remembering to do something on your schedule, right? And so this is usually typically diagnosed by a doctor, a neurologist. And so what we're hoping for with ADUHELM or with some other lifestyle modifications is that we can slow this progression, right? But it's important to know that everyone who experiences dementia passes through mild cognitive impairment. So what does that mean, right? So when we have an opportunity to prevent new cases of mild cognitive impairment, we can prevent new cases of dementia, right? So this gives us some real opportunity, some hope from a pharmacologic perspective and from a public health perspective. And I'll talk about that as we move into our discussion of disparities and diversity, that second bullet. Now, so Alzheimer's and dementia, public health priority, something very important for public health to consider. Within that public health priority, there are disparities that exist, right? So almost 2/3 of Americans with Alzheimer's are women. older Black and Hispanic Americans are more likely than whites to have Alzheimer's or other dementias, right? So when you think about these disparities, what comes to mind? Is it a genetic disposition? Is it access to resources? There are a number of factors, what I might call a constellation, like constellation in the stars, right? So many factors that could be at play. And I'd have you think about those in two ways as we move forward. Those that are fundamental, those that are relevant for all communities, all populations, and then maybe those that are unique, some that are maybe linked to specific aspects of a certain population's or community's life experiences in this country, right? So really interesting to think about those, but two ways, fundamental and unique, okay? So here when we look at LGBT adults, really interesting report that you can find on the Alzheimer's Association website, alz.org. You see that there are some unique circumstances here with LGBT adults reporting some perception of being treated unfairly because of their sexual orientation if they sought dementia care, or many of the LGBT adults in this report said that they lived alone, so they don't receive the kind of social support that might be needed, right? So there's some unique circumstances for certain communities, right, that we have to understand when we want to properly characterize risk for, in this case, LGBT adults, right? And so that's an example, I think, of a factor that factors that are unique. But certainly what could be fundamental is being able to access healthcare, being able to see a doctor. That's a fundamental factor for everyone, to see a doctor in a timely manner so that a doctor can help you with that continuum, slow that continuum from mild cognitive impairment to dementia, right? So just an example, fundamental, being able to see a doctor, right? Being treated unfairly in the healthcare system might be a unique circumstance for a specific population. So all of this, points to this field of health disparities research. And I tell you, when I was with the National Institute on Aging, I had a chance to work with colleagues to develop a framework where we tried to organize these many constellation of factors into what we called levels of analysis, those that occur in the environment, those that are sociocultural and maybe unique, those that are behavioral, right? And then finally, how all of that comes together to influence biological factors, or in this case for Alzheimer's and dementia, the amyloid, tau, and neurodegeneration that occurs in the brain, right? So really interesting to think about how to characterize and organize these constellation of factors, right? And so think about those levels of analysis, but also the way that we're going to remember to think about this moving forward, fundamental factors and those that may be unique. Well, luckily for Alzheimer's and dementia research and care, the Lancet Commission went a step further, and they have identified what they called modifiable risk factors, right? And so in their work, in the Lancet Commission is a collection of very smart investigators who scanned many studies all around the world, right? And so they came up with a finding and reported it during the Alzheimer's Association's International Conference in 2017 that 35% of global dementia was preventable, right? And so in that, they identified a number of modifiable risk factors. Here you can see a few. Certainly, they said that education was important, smoking, right? Diabetes, hypertension, right? So there are quite a few factors that are related to vascular health. And remember, I asked you to put a pin in vascular dementia, right? So they said in this finding that 35% of global dementia was preventable. Many of these modifiable risk factors were linked to lifestyle, Obesity was one of them, right? And so they came back in 2020 and they added 3 additional modifiable risk factors: air pollution, traumatic brain injury, and excessive alcohol use. So think about those levels of analysis for health disparities. Air pollution, where people live, right? How can that influence risk for Alzheimer's and dementia? Really interesting, right? And traumatic brain injury, I think about the employment opportunities that people choose and how that puts them at risk for traumatic brain injury, serving in the military or choosing a job that puts you at risk. And then excessive alcohol use. Really, really interesting, right? Because as we're all, persevering through the pandemic, people are coping in ways that could be unhealthy and unhealthy behaviors, right? So the take home here is that there are things that people can do, according to the Lancet Commission, to reduce their risk. And that global dementia could be 35% of global dementia is preventable. Really, really intriguing to think about it in that way. Now, we didn't forget about genetics, and the Lancet Commission didn't either as well. They identified ApoE4 as the risk, correctly as the risk gene for Alzheimer's. But research is telling us more and more that ApoE4 is not as relevant for disparities. So here there was a researcher who attended our Alzheimer's Association conference in 2020, and they found that this gene was less predictive for Hispanic Latino populations. And this adds to a growing body of research that says that it's not the genetic or biological factors that are most attributable for the disparities that we see in Alzheimer's and other dementia. So if that's not the case, then let's think a little bit about that constellation of factors that are fundamental and that are unique, right? And when we're thinking about health disparities, we need a theory to guide us, to guide how we interpret some of these factors. And so let's go back to your sociology class or your social work class in high school. And there were some founding philosophers that helped to guide the way that we think about community differences or population level differences. And so here's Max Weber, German philosopher, and he really honed in on the strength of group norms or group values, or what we might think about as lifestyle factors, right? So the choices that people make, the ways that they live lead to various outcomes, some better than others, right? Really, really interesting. And this goes right into some of the Lancet Commission's findings and some research that we see that was reported during the Alzheimer's Association International Conference in 2020, where a researcher found that BMI, body mass index, was really important, right? And so a higher body mass index along the life course was associated to late life dementia risk, right? Really interesting. So those things that you do, right, for your diet or the nutrition, the physical activity decisions that you make, could have implications for your risk for Alzheimer's or dementia later in life. Really, really interesting. And this adds to a study, a really important study in this field, the Sprint Mind study, right? And so in 2019, this was the first study to demonstrate a reduction of new cases of cognitive impairment. Remember, we said everyone who passes through to dementia goes through malcognitive impairment, right? And so in this study, getting blood pressure down to 120 systolic led to a reduction in malcognitive impairment, I think 19% reduction, and then a combined reduction in malcognitive impairment and dementia, right? Really interesting. And this had a nice representation of African Americans as well, which is an issue in this research. We'll get to that. But this, again, doubles down on the fact that there are things that people can do. And in this case, a doctor helped people get their lifestyle choices under control by helping them with healthy eating and improving their physical activity to lowering that blood pressure to 120 systolic. And we saw a reduction in risk for MCI and dementia. Really, really interesting. So the Alzheimer's Association is leading the U.S. Pointer trial right now. It's the U.S. study to protect brain health through lifestyle intervention to reduce risk. And so this study is taking those findings from the Sprint Mind study and seeking to understand the recipe of physical activity, nutrition, cognitive stimulation, right? And then health coaching. And so how can that all come together in various study sites around the country so that we can more fully understand the impact of lifestyle factors on Alzheimer's risk, right? So interesting, we're recruiting right now. It's going to give us some really compelling and I think impactful findings on lifestyle. You know, like Max Weber said, the choices that people make and how that can reduce their risk for Alzheimer's or dementia. Well, when we think about that sociology class, Emil Durkheim, also a philosopher who is noted as a founding member of the field of sociology, he had a different take on group differences, and he basically said that the condition of the social organism is what's most important, right? And so, differently than people's collective norms and values, he said there was something about the interactive way that people live together in society, and that had a way of influencing group norms. Some people had access to resources, maybe others didn't, right? So really interesting, a different take on some of the group differences that Max Weber observed. And there's been some research that has focused in on what we might call social class and dementia, right? And so here, socioeconomic status is measured by education. It's a composite measure of education, income. So the more education you have, the higher class, the more income, and then occupational status, right? So if there's a class of employment opportunities and they are ranked, right? And those with the highest are in the highest class. And here, some research from investigators at Columbia University found that those who had the highest socioeconomic status or social class remained dementia-free the longest. And in this particular study, there was a high participation of Hispanic Latino participants in this particular study, right? So interesting to think about the influence of access to resources that links very nicely to the ways that Emil Durkheim, thought about group differences, right? So we've moved through lifestyle, we moved to access to resources, social factors, and then there's another take on this. And so Dr. W.E.B. Du Bois, he's the first African-American to earn a Ph.D. from Harvard University. He earned that Ph.D. in sociology, right? And so he doubled down on Durkheim's assertion of social factors and said, well, access to resources is really important, but there's something about race and ethnicity in the United States that we have to fully understand, right? The stress of opportunities, the stress of being, in his case, a Black American in this country that we have to fully investigate to understand some of the outcomes for Black Americans in this country. Let's think a little bit about Dr. W.E.B. Du Bois's assertion of the importance of race and ethnicity in the United States, and the fact that resources that Emil Durkheim mentioned are very important in understanding group outcomes. So let's look at education. The Lancet Commission, as you would recall, identified education as a modifiable risk factor in their assertion that 35% of global dementia was preventable, right? So education is really important when we think about disparities in Alzheimer's and dementia. So let's look at some data from the National Center of Health Statistics. These are health disease death rates in the United States from 1993 to 2001. Now, just a quick refresher, with the ratio, 1 is equal. And when you're comparing two groups, if the ratio is 1, that means that they're equal. And as education increases here, right, you would think that more education means that In this case, the black-white ratio would be closer to 1, right, for both men and women. But the data here shows that the disparity widens as education increases. And health disease death rates are really interesting because some of the same factors that put people at risk for heart disease death, diabetes, stroke, hypertension, are very important, same risk factors for vascular dementia, right? And so interesting to think that the resource of education doesn't have the same protection for African Americans, in this case, for heart disease death rates. What could be the issue? What do you think? Well, we'll get to we'll come back to 2021. Great discussion on sociology, but I tell you, that was a really important, impactful report that was made available by the Alzheimer's Association on race, ethnicity, and Alzheimer's in America. You can find this at alz.org/facts, right? Really, really important report. And what makes this important is not only its focus on race and ethnicity, but the representation of African Americans, Hispanic Americans, Native Americans, and Asian Americans and white Americans in this report. And so we mentioned that one of the fundamental factors in understanding these disparities is being able to see a doctor in a timely manner, to receive a timely diagnosis. Well, in this report, more than 1/3 of Black Americans and nearly 1/5 of Hispanic and Asian Americans believe that discrimination would be a barrier to receiving Alzheimer's care. And I note discrimination here because when we remember the data on heart disease death rates, could it be that people who acquire more education are perceive or experience more discrimination? Or could it be that once they obtain the many years of education and degrees that there's a stress of life that Dr. Du Bois mentioned in terms of not receiving the return on that investment? But there's something in the discrimination space that we've got to understand, and it's relevant to data that was published in 2021, right? And so not being able thinking that you would experience discrimination when accessing dementia care is important. And the number one reason here was that people thought that they would be treated unfairly because of their race or ethnicity. Really interesting, right? So if seeking care is a behavior, and if people think that they would be treated unfairly, they're less likely to make that decision, and they're losing time. They would see a doctor when it's too late or farther along in that continuum. Really, really important. Also in that special report, half of Black Americans report actually experiencing healthcare discrimination. At least 1/3 of Native Americans, Asian, and Hispanic Americans did as well, right? And so the first table showed a perception. They believed that they would experience discrimination. This data shows that people actually experience it in the healthcare setting. Again, the fundamental factor is being able to receive a timely diagnosis. If people are being treated unfairly when they get there, then we've got some work to do in terms of improving dementia care and making sure that there are standards around cultural competence, care delivered with humility. Really, really important. Also thinking about the diverse pathways to risk when we think about some of those cardiovascular outcomes that I mentioned, diabetes, obesity, hypertension. There are disparities in those outcomes as well, right? So we have to understand what are some of the factors that we can attribute to these disparities in many of these outcomes that occur along the life course that put people at risk for Alzheimer's and dementia. Really, really, really is important. And there's a strong literature that links stress and discrimination to some of the ways that people cope and they are at risk for these outcomes. And I mentioned that the Lancet Commission identified air pollution as a modifiable risk factor. Well, there was a recent article that was published that highlighted the work of Dr. Robert Bullard. And he came up with an area called environmental racism, right? And taking a contextual look at how people come to live in the communities that they reside in. And many times those communities have been built and designed because of redlining, and people live close to expressways or very close to industrial pollutants. And over time, right, this is an area where people, a contextual, an environmental level of analysis, and people are exposed to toxins that put them at risk for a host of outcomes, including, as the Lancet Commission mentions, Alzheimer's and dementia, right? So we have to think about this from an upstream perspective as well. If you get a chance, take a look at, try to find environmental racism from Dr. Robert Bullard. Really, really good read there. So as I begin to wind to that third bullet to talk a little bit about inclusion, when we think about diversity in Alzheimer's and dementia, it's not only the people, the representation, that the racial ethnic representation that we have at the Alzheimer's Association. We need more, but it's also thinking of the diverse perspectives for dementia risk, right? And so we have to fully understand those environmental factors, like redlining or like having access to quality health care in your geographical area, how that links to sociocultural factors, discrimination in the healthcare setting, discrimination anywhere, which leads to coping behaviors, how that influences the choices that people make, the foods that they eat, the physical activity, the other behaviors that are so important here, and how all of that leads to a pathway, right? A pathway to risk that influences that amyloid and tau and neurodegeneration that characterize Alzheimer's and dementia. So we really have to understand the unique pathways to dementia risk for all communities, and particularly for those that are disproportionately affected. We know African Americans and Hispanic Americans are more likely to have dementia, and those that are understudied, we really don't have the information that we need, like American Indian, Alaska Native communities or LGBT populations. Really, really important from a disparities research perspective. So let's turn our attention to the third bullet, which is inclusion, right? And so I've mentioned the importance of health disparities research, understanding these factors for those populations that are most at risk. Well, unfortunately, less than 5% of trial participants are African American, Latino, Asian American Pacific Islander, or American Indian Alaska Native. Put another way, less than 5% of trial participants aren't white, right? So the people that are most at risk that we need to study to really understand and make an impact on this devastating disease aren't being recruited into the clinical trials for Alzheimer's research. Really, really interesting, right? And if you're following this, you know, the folks that are most at risk, not being recruited, and when they are included into a clinical trial, or we get people to a dementia care facility, most clinical trials take place at a dementia care facility, they feel as if they're being discriminated against or treated unfairly, right? So we've got so much work to do, I think, in this area, in the area of inclusion, intentional inclusion, and being sure that we are making people feel like they belong in a dementia care facility and in clinical trials, right? Because that's the only way that we'll be able to conduct rigorous health disparities research. The Alzheimer's Association is advocating for an act, and Congress is considering this right now, Equity in Neuroscience and Alzheimer's Clinical Trials Act. It's called ENACT. So if you get a chance to see this, please endorse it and show your support for it. But this will give resources to those Alzheimer's disease research centers. Remember earlier in our talk, I mentioned the centers all around the country that are in academic institutions. Well, this act will provide resources to those centers to recruit underrepresented staff to work there in the center so that people can see people that look like them when they're being recruited into a clinical trial, but also to give them resources to evaluate barriers for clinical trial participation. Sometimes people aren't really thinking of some of the bioethics atrocities that we know have happened. The Tuskegee syphilis study is one of them. Sometimes people are dealing with transportation issues or the barrier of timing and being able to participate at a time that works for them, right? So this will give researchers additional resources to do more in inclusion, right? And to be sure that more people are having the opportunity to benefit from the resources and the research that are taking place in Alzheimer's and dementia. So this is more about ENACT, but again, enhancing the diversity of clinical trial staff, reducing participation burden, and expanding access and increased outreach, right? And sometimes that's going into communities and actually setting up the clinical trial in the community. So if you see ENACT, please show your support for that. We'll really appreciate it. The Alzheimer's Association is also leading the New Ideas study, and it has two important goals from my perspective. One, it is assessing if PET imaging is taking pictures of the brain, right? And this was just a revolutionary finding about 20 years ago. We can actually see Alzheimer's in the living brain. Really, really important, right? But in making this finding, there was a missed opportunity to include diverse racial and ethnic populations, right? And so the New Ideas study is going to focus in on recruiting 2,000 African Americans and 2,000 Latino study participants. So not only will the findings around PET imaging for these populations be very important, it's going to be impactful to this field, we're also testing some community-based methods in how to best include these populations into the research, right? And so this will take a community-based approach where researchers will be partnering with local organizations to increase trust and awareness of Alzheimer's and dementia and why PET imaging is so important, why participating in a trial is so important, right? So much to gain from this study. The study principal investigators, Dr. Maria Carrillo, our chief science officer at the Alzheimer's Association, and many others, Dr. Peggy Dilworth Anderson at UNC Chapel Hills, leading our community engagement core, Dr. Consuelo Wilkins as well. But we're really testing a few hypotheses here, and one of those that is quite intriguing is the use of community-based methods to recruit underrepresented, disproportionately affected populations into this research, right? So be on the lookout and look to hear the findings from the New Ideas study, right? So as I begin to close here, from a diversity, equity, and inclusion perspective with the Alzheimer's Association, we certainly advocate for multi-level health disparities research, right? And so I open with the philosophy of Max Weber and a focus on lifestyle and the health behaviors and the choices that people make are very important, but it all happens within a context, right, of how people live and the resources that they have, like Emil Durkheim mentioned. And then there's some unique circumstances, unique factors, right? We talked about fundamental factors and those that are unique. There's some unique factors that we've got to understand, like discrimination in society and how that impacts people's decision-making, which could ultimately influence their risk for Alzheimer's or another dementia. So that's multi-level health disparities research, focusing in on context. We certainly also advocate for diversity in health systems and health-related institutions, right? So more pipelines, opportunities to bring people in to work in these organizations who are from communities that we'd like to better include. Third, we can all do more with cultural competence in dementia research and care. So being sure that there are accountabilities and compliance areas for enhancing cultural competence, but not just competence, delivering dementia care with humility, right? So if that report that the Alzheimer's Association published this year on race and ethnicity showed that people perceive and experience racial discrimination, their number one factor for the discrimination was that they didn't feel like they were being heard. So delivering care with humility is so important so that more people can get a timely diagnosis. And then finally, we would focus on participatory engagement to build trust in agency. And that is what we're doing nationally with the Alzheimer's Association. As I mentioned, we have over 70 chapters around the country. And we really focus on what we might call community-based participatory engagement, right? And so that is working with national partners who many of them also have a local presence in many of the cities where our chapters are located, and finding ways to align their chapters or their entities with our chapters so that we can deliver care in a culturally competent manner with humility, right? So for example, you see here we work with the African Methodist Episcopal Church, right? And they have churches all over the country. Our goal is to activate these partners locally so that we can do more in African American communities. Or the National Hispanic Medical Association, they have chapters all around the country. To the Tzu Chi Foundation, where we can do more with Asian American Pacific Islander communities. So really looking to partner and work together so that we can deliver our resources. The Alzheimer's Association has many resources that are free of charge that we'd like to do more in terms of engaging and having underrepresented, disproportionately affected communities be able to utilize in combating Alzheimer's and other dementia, particularly with caregivers, many great resources for caregivers. So the opportunity here is that we certainly can do more to change the trajectory of Alzheimer's disease. So this graph here shows if we develop an Alzheimer's treatment that slows this continuum by just 5 years, by 2050, 5.7 million people who are expected to develop Alzheimer's would not. 5.7 million people. From a diversity, equity, and inclusion perspective, we want everyone to have a chance to be in that number, no matter where you live, rural or urban, or race, ethnicity, or how much education, all the things that we talked about, the constellation of factors that lead to disparities. We have to understand all of those so that everyone has a chance to be in that 5.7 million people. And hopefully we can increase that number with new treatments, new understandings of lifestyle and how context influences lifestyle. Really important, right? And so this leads to what I think is probably the most important work in Alzheimer's and dementia care and research, and that's diversity, equity, and inclusion. One is keeping an eye on who's most affected, right? Understanding those diverse pathways to risk, being intentional about our inclusion, not only including underrepresented people into clinical trials and working at Alzheimer's disease research centers or in studies, but thinking about those perspectives as we understand research. And then equity, keeping equity top of mind, right? And that equity is different from equality. Equality is we've got resources, everyone gets the same type. Equity is understanding the needs of communities and delivering those resources in a way that they can utilize them in a way that is culturally competent with humility. Really important. So I would think diversity, equity, and inclusion is fundamental and central to everything that we do if we'd like to make an impact on disparities. Again, equity is achieved when every person has the opportunity to be in that number. And we certainly advocate for more in that way. Here's a graph. It just shows that there are various pathways along the life course, right? If the finish line is staying dementia-free the longest, we have to understand that people have various barriers. Some have discrimination. Some have, not enough access to care, right? So some have language barriers. We have to make sure that we are shaping our resources, being sure that we're delivering those resources in a way that everyone can utilize. So critical, so very important, right? And we have a legacy that we can that we can work from here. So when we think about the hallmarks of Alzheimer's disease, again, the three hallmarks are amyloid, tau, which are proteins that cause neurodegeneration, right? So those amyloid causes plaques in the brain, tau causes tangles, and all that leads to cell death, which is called neurodegeneration. Well, that was discovered by Dr. Alois Alzheimer's there on the left. He had a diverse perspective. He had a different idea. In early 1900s, his thought was that some of the behavioral changes that he noticed among people, older adults, had to do more with biology than simply growing older. That was a provocative idea at the time, diverse perspective, right? And so in answering that research question or going after that hypothesis, he assembled some of the great researchers around the country. And one of them was Dr. Solomon Carter Fuller, who finished an historically Black college or university, Livingstone College in North Carolina, and went on to medical school at Boston University, finished medical school in 1897. And because of some of the racial discrimination, we've talked about that today, that was occurring at the time, he was unable to pursue the research career that he envisioned. So he was relegated to performing autopsies. Well, those of us that finished in HBCU, he got really good at performing autopsies. So good that he was recruited by Dr. Alzheimer's to his lab in Germany to help pursue that research question. And together, they, with other researchers, found the biological aspects of Alzheimer's disease, the amyloid, tau, and neurodegeneration that we pursue today. So we have a legacy of diversity, equity, and inclusion. And the 2.0 of this is to think about the diverse pathways to risk that we have to understand so that all communities can benefit from the exciting research that is taking place today. Here's a picture of the diversity, equity, and inclusion team at the Alzheimer's Association. These are wonderful colleagues that are doing great work in this area. And my colleagues are available 24/7 to answer any questions. And if you have any ideas of organizations that we should work with, please call me at 800-272-3900. I'd love to work with you. Vast information at alz.org. Thank you for participating, and I look forward to a discussion.